Hello, everybody, and welcome to the Semados Campus web seminar for professionals. My name is Marcio Garcia dos Santos. I'm part of BEGO Implant Systems education and clinical research team, and I will be the moderator of today's session. First of all, I hope that you and your family are all in good health. Before introducing our speaker, I would like to thank Mrs. Angelica Jacob from BEGO Implant Systems Marketing Department for the organization of this session. The topic today will be Stomatognathic system stability, analog and digital approach, and the speaker will be Dr. Ilia Russo from Greece. Dr. Russo received her undergraduate degree in dentistry from the National and Kapodistrian University of Athens in Greece, her certificate in prosthodontics from the graduate program of the Temple University, Philadelphia, USA, and the certificate in oral facial pain from the University of Kentucky in Lexington, USA. In 2004, she obtained her PhD degree from the National and Kapodistrian University of Athens, Greece. Following her professional training, Dr. Russo established a private practice in Athens, limited to prosthodontic and oral facial pain treatment. She's assistant professor at the Department of Prosthodontic of the University of Athens Dental School in Greece, active member of many professional societies, including the European Academy of Craniomandibular Disorders, the International College of Dentistry, the European Prosthodontic Society, and the European Osseointegration Society. She lectures extensively nationally and internationally, and her topics of specialty are orofacial pain and temporomandibular disorders, occlusion and occlusion discrepancies, fully digital approach of full mouth rehabilitation. Ilia, my friend, thanks for accepting the invitation to conduct this session. As always, at the end of the lecture, we will have a question and answer session with the speaker, and you can place your questions in the question box during the whole presentation. I wish us all a very nice time, and I give the words to Dr. Russo.
Thank you very much, Marcio. And for the invitation, I would like to thank BEGO for giving me the opportunity to be here with you today, and of course, Angelica for organizing everything. I think I can share my screen now. So, okay. I hope everything is okay.
Great. Perfect. Everything's perfect. Thank you.
I would like to congratulate you for your good Greek, because I believe that the stomatognathic system stability, but the word stomatognathic, it's not so easy for everybody to pronounce it. I would like, as I said, to thank for the invitation, and actually thank you for the topic. It's probably the closest to my heart, and I really like to lecture and share the information about this very, very important topic that I believe applies to any dentist, except maybe for the endodontist, but for anybody else that does everyday dentistry and places restoration and are concerning about the occlusion, this topic is close to our heart for every general dentist, I would say. So I prefer, maybe because I'm Greek, to actually refer to the stomatognathic system stability as the 3 sigmas, because I think it's easier to remember. As I said, I'm Greek, so maybe this is one of the reasons. And also, when I showed this to some students, to graduate students at the university in the US that I had this similar lecture, they told me about the very famous sorority, student sorority, that's called the 3 sigmas. So I don't know, maybe I got influence from that as well. So as Marcio mentioned, I'm from Greece. Actually, my mother is German, so I have both nationalities, but I was born and raised in Greece. I did my undergrad studies here at the University of Athens, and this is where I also practice today, and I have my private clinic, but I also work at the university. These are the two different wards that we have today. So this is the class that graduated in 2019 and the one that is going to graduate this year. Although the different issues that we had, we managed to train the class that is going to graduate in 2021, and actually in 1 month it's going to be their graduation during this pandemic area. I also have a private practice that I practice only prosthodontics and orofacial pain. As Marcio very nicely in his kind presentation mentioned, I did my graduate studies in prosthodontics at the University of Temple in Philadelphia. The reason why I'm mentioning is that during your prosthodontic training, and actually what I see for the most of the undergrad students and the most of the dental schools that I'm familiar with, the way we are trained is in a very strict way. So we learn to use a lot of hardware, and we learn to rely a lot on articulators and face bows. And actually, if something goes wrong within the communication from the lab, so when things come back from the lab and they don't look the way we design them or would expect them during our clinical steps, we would get very frustrated and think that something went wrong either from our side or from the laboratory side. So we learn all these different movements, and we learn to work with values that are very, very difficult to record, like the immediate and progressive side shift. And this is the everyday life for a prosthodontist or for a general dentist that really wants to go into details about the restorative procedures. So this is the picture of a patient that we were trying to record the movements and just to have the articulator functioning according to this type of movements. And this is a procedure that takes about a couple of hours. And I'm not sure that all of us can recognize what we're getting, the results that we're getting, and how we can use them in order to perform a better prosthetic rehabilitation. After finishing my studies at the University of Temple as a prosthodontist and having this mindset that I was explaining to you, I continued my studies in Kentucky and studied orofacial pain. And that was a totally different world. My presumption was that I would go there and understand a little bit better how the TM joint works and how CR could work and how my whole recordings could be applied for a more effective prosthetic rehabilitation. And this is where I met Jeff Okeson, and I really mention him in almost all of my lectures because he changed my mindset. And he made me realize that we as humans and the way the whole stomatognathic system is functioning has nothing to do with the articulator and all the hardware that I showed to you earlier. It's a totally different environment. And for us, having in our mind that everything works as the hard metallic surfaces of an articulator is wrong, and is guiding us to many frustrations during our clinical practice. So he introduced me to the biological aspect of the whole stomatognathic system. He changed my mindset, and since that, it's been now for 20 years that I've been practicing and developing these ideas. I believe that it changed my way of practicing, my way of approaching the cases and my patients, and this is actually what I would like to share with you. So, as I said earlier, I practice prosthodontics, and a lot of these cases are really straightforward. And I see a lot of pain patients that have problems with their occlusion and pain issues in the whole face area and also in the TM joint. So these are two distinct types of patients. But in some cases, and these are the cases that I will share with you, the stomatognathic system stability is jeopardized. And these are the cases that we really need to think a little bit more biologically. So this is where the 3 sigmas come from. It's actually a Greek word, as I told you, but it will help us understand and establishing a stable and balanced environment where we need to work with. So let me show you a couple of cases, and just to make my point and introduce to you to the issues that we all face every day, and maybe sometimes we don't really think about it, what might be happening. So these are all cases from my practice here. This is a young lady, 42 years old. Her chief complaint is that she has a lot of pain during function and that her bite changed. So she told us that, I could bite on a sandwich with my anterior teeth and now I cannot do that anymore. And really what we see by first checking the occlusion is that we have an anterior-posterior open bite. Now with the digital procedures, we can check immediately and easily exactly how much the distance might be between the teeth. So here you see after we get the intraoral scannings and the occlusion relationship, these are the contacts that she is having, and that she has only contacts on the second molars, and everything else is out of occlusion, and we can see exactly how much the distance is between all the way up front to the first premolars. So we have some problems and occlusal instability. Of course, in cases like that, we should check the TM joint. So a CBCT of the TM joints will show us exactly if there is any pathology that would explain to us this occlusal relationship. And you can see that we have nicely shaped condyles and the glenoid fossa as well. So there is no etiology within the joint. Now, if we either print the casts or take 2 alginate impressions of the patient and hand articulate it ourselves, we can see that she is capable, the way that her teeth are, we have a stable occlusal relationship. So a stable occlusal relationship should be possible for this patient. But something happened that the whole mandible now is relaxing, is stabilized in a different relationship. So the 3-dimensional relationship of the mandible against the maxilla changed completely. And this is not because of her teeth. Her teeth allow a stable occlusal relationship. So there's something else that happened and changed this occlusal relationship. Here you can see the movement that she's performing. Okay, we see a little bit of a deflection, but there's a good range of movements after our therapy and once the pain symptoms were addressed. But still, the occlusal discrepancy is present. Okay. So this might be the first, and I'm pretty sure that a lot of you might have similar cases in your practice, because this is very common, at least for us in our practice here. Now, let me share with you another case. This was done by an excellent prosthodontist in our area, and the patient was referred to us because about 6 months after the prosthetic rehabilitation was done, and this included some ceramic onlays on the posterior teeth. So the prosthodontist replaced some all amalgams with ceramic onlays on the posterior teeth. Without having any pain symptoms, the occlusal relationship changed. And as you can see, we only have contacts again on the second molars. So this is also very common after orthodontic treatment. So something is happening, and although when the case is delivered, we have a stable occlusal relationship, something is happening down the line, and the 3-dimensional position of the mandible against the maxilla changes. Okay, so now we have to think a little bit what might be happening, and again, think about the stomatognathic system stability. Just keep in mind that the mandible is actually floating, okay? It comes against the rest of the cranium in 3 places, the 2 TM joints and the occlusion. So this three parts have to be in a total balance together and working in a balanced way together in order to provide a stable relationship of the mandible against the rest of the cranium. So there should be this constant balance between those three elements, and this has been dictated by the muscles. I'm sorry, so the masticatory muscles. So this is how the mandible rests against the rest of the cranium on those two TM joints and the occlusion. So it makes sense that if something changes within the TM joint, the position of the mandible will change as well. So if we have a patient like that, where you see we have significant arthritic changes in the TM joint, and actually we have also contact of the articulating surfaces during opening of the mouth. So there is some pathology within the joint that would explain this occlusal relationship. So the orthopedic instability that the patient presents with. On the other hand, let's look at this X-ray, again the CBCT. You see this huge osteoma that the patient developed in the right TM joint. The left side looks great, but in the right joint, we have now a region, a local region within the joint that would, of course, explain why the occlusal relationship that this patient presents with changed. He never was a class 3, but that's how his occlusion developed. So these are cases that we see in our everyday practice, maybe not that often, but still we see these cases. And although the stability of the stomatognathic system is now compromised, we need to provide a more functional, stable relationship for these patients. On the other hand, as I mentioned, the whole mandible is being kept in place from the masticatory muscles. So if we have some pathology within the muscles, the masticatory muscles, and especially the lateral pterygoid, the position of the mandible against the rest of the cranium will change again. So it's very common that we see patients that come, and this is just a picture to show how complicated the masticatory muscles are around the mandible and how complicated our approach would be in order to find a balanced relationship of all these structures. So it's common, usually when we see patients that have a posterior open bite, so it looks like if the mandible moved to a more forward position. In most of the cases, this is due to a masticatory muscle disorder. So we have this young lady again that presents with this type of occlusion, and she has a lot of pain, TMD pain. So the first thing that we should do in cases like that is give a name to the problem. So have a proper diagnosis, and the proper diagnosis for a case like that would be myalgia of the masticatory muscles. Okay, so we go ahead and do all the treatment options that we have for cases like that, which would include the use of anti-inflammatory medications, do some trigger point injections within the muscles, physical therapy, and of course the stabilization appliance. So once we treat the pain symptoms, we realize that the occlusion is stable again. So it's good for us to realize how this all interacts together, because the patient was referred to me as he came on the picture on the left in order for us to put some onlays and give her a stable occlusal relationship. Imagine if we would have done this approach and give her some occlusion relationship, but in an unstable environment for the whole stomatognathic system. I know that this is a little bit fast and maybe it's not so easy for everybody to follow. This is actually a 2-day seminar that we are having, but I would like at least to give you an introduction of my way of thinking and the approach that we have here in our practice. So if we realize that, we now know that we shouldn't check occlusion as a separate unit. So most of the dentists, what they do, they ask the patient, open your mouth, and they look immediately inside. we have to take a step back and realize that occlusion is one part of the whole stomatognathic system that can be affected in the same way that any other unit of the stomatognathic system can affect it. And this could be the skeletal bony part, it could be the temporomandibular joints, the ligaments, the muscles, and of course also the dentition. So we should make sure that we go a step back, and before we grab our handpiece, make sure that we try to achieve or at least diagnose the stomatognathic system stability or instability that the patient presents with. Okay, now I would like to share with you a few cases just to make my point of what we discussed until now. Remember that it's very important to realize that the TM joints don't work the same way as the articulator does. So we have soft tissues that we can compress and decompress. Actually, during function, it's happening all the time, and the joint and the movement of the articulating of the three articulating surfaces and the disc are constantly moving in order to compensate for the movements and the function that is happening and the forces that are applied within the joint. And this is something that we can certainly not reproduce on the articulator. So therefore, we have a huge difference between those two elements. Of course, we need the articulators. It's the only way for us to communicate with the lab. But let's keep in mind that these are not exactly a reproduction of what is happening within the joint. And you know, we learned in dental school that the joint is a spherical, the condyle is a spherical component, but this is not what we see in real life. This is a CBCD again of a patient that is totally symptomatic. But this is how the morphology adapted to the forces that are applied for this specific patient. Is that what we have in mind from dental school about how the condyle should look like? No. And then we know that during CR, you know, there's the condyle should do a very smooth rotational movement and then a transitional movement. But again, we have now the ability to see with different with different machinery and digital dentistry like this CBCT from Planmeca that also at the same time can track the real-time movement of the mandible in a 4D dimension. And we see that this is not what we had in mind, so that there's a pure rotational movement and then a transitional movement of the condyle. And moreover, if we think about function, okay, and this is where our restorations have to function once we deliver them, and we deliver them in a stable occlusal relationship, and then the patient goes on and functions and has mastication and speaking and swallowing. And you see that these are movements that there's no way that we can predict and reproduce, but they would affect the stomatognathic system stability. So this is why we prefer now to use mostly the muscularly skeletally stable position rather than CR. And I will make my point in a moment. Okay, so now I think I discussed a lot about the stomatognathic system stability and the muscularly skeletally stable position that we need to establish, we need to maintain, and we need also to be ordered to register. In order to establish, first of all, and then maintain the muscular skeletally stable position, we use a stabilization appliance. So the stabilization appliance would allow us to guide the mandible to a position that the muscles are the ones that are guiding it. So see, look at this case. Even in very demanding cases like this one, we have a heavy fracture patient that we need, though, to restore the loss of the tooth structure. So with the stabilization appliance that we are using in this case, look how the relationship of the mandible against the maxilla changed. So how much the mandible went to a more posteriorly position. And this is actually more closely to what he also remembers to have as an occlusal relationship. So he moved to a pseudo class 3 because this is how he could function easily in order to have more occlusal contact. But the one that was guided by the muscles and it's more stable for the 3 sigmas for the stomatognathic system stability is a more posteriorly one. And this is the one we should use in order to make our final restorations for this case, which would be only on the posterior teeth and veneers, ceramic veneers on the anterior teeth. But before we go and do any prosthetic, we have to make sure that we are maintaining the stomatognathic system stability by finding the musculoskeletal stable position. I'm sorry. Okay, so for the stabilization appliance, in our practice, we use digital dentistry for all of our cases. It's easier to make them and they're certainly more precise. And actually we used to, I'm sorry, to use a 3D printer and print our appliances, but I really believe that the materials are not yet there for what we want for a stabilization appliance. So it would be better if you mill your stabilization appliances, and we have all the possibilities and the materials, and actually you can send your files to BEGO and they can mill for you a PMMA appliance splint. Okay, so this is how it looks like, and then we just need to adjust it. So the registration would be done with an anterior deprogrammer or a COIS appliance. And it looks like that. It's being used in the anterior area, and all we need is to have some space between the posterior teeth in order to register this new musculoskeletal stable relationship. Okay, let's see now a few cases, so that I'm going, everything that we discussed as now, show you how we apply it in the clinical practice. So this was, when I saw this lady, she was 52 years old, and she had some aesthetic concerns. Okay, and most of the dentists that she visited told her that she needed to have an orthognathic surgery at this age in order to correct this type of occlusal discrepancy, although it's a stable occlusal relationship which she presents with. But nowadays, with the materials that we have and the possibility to opening the vertical dimension of occlusion, I think most of these cases can be dealt maybe in a more compromised way, but can certainly be dealt with prosthetic means. So again, with the stabilization appliance, we are finding the musculoskeletal stable position, and then all we need to do is decide how much we want to increase the vertical dimension of occlusion. And once we do that, again, in a digital way, we can, you see how much we open the vertical dimension, which is not really a lot. It's about 1.5 millimeter in the posterior area. But now we can go ahead and design, at least diagnostically, and see if we can make a better restoration in order to provide a stable occlusal relationship within the limits of the stomatognathic system stability of this patient. So this would be the provisional that we are designing. It would be cut out of PMMA again. So the patient comes back, we remove all the old restorations that she has, and then place the new PMMA provisional restoration. And look immediately how good the function is. Although she had this shifting of the mandible due to all the restorations and the way the occlusion was detecting the movement, now she has a stable occlusal relationship. And of course, the aesthetic that we can provide with this type of treatment is totally different, okay, in a very non-invasive way. So this is now the provisional restoration that we can leave there, see how it will function, read the occlusal marks that will happen during function on our restoration, and also have the opportunity to see which of the teeth will be still there and provide us for a stable final restoration. But again, we are functioning within the limits of the 3 sigmas of the stomatognathic system stability, which I believe is very, very important for cases like that. Now, let me share with you another case that actually we started yesterday, and I just put the pictures for you late last night together. We have a young patient in her 50s again. I think she's young, you know, probably because she's close to my age. And beside the missing teeth on the lower right side, we have some functional issues because the way she's occluding, it's with her lower incisor against the palatal aspect of the upper anterior teeth. So there's always this trauma to this area that it's a really concern for this patient. So we decided when the implants were placed, here you can see how the occlusion was, when the implants were placed, that we would like to increase the vertical dimension of occlusion. So once we were ready to use the implants and get some impressions of the 2 implants. Here you can see the digital impressions that we got, and we decided to increase the vertical dimension of occlusion in order to address also the relationship of the anterior teeth. So here you can see that by increasing the vertical, we got some prosthetic space that we can work with. Now, of course, we did the PMMA provisional restoration that was adhesed on the adhesive abutments. So this is the provisional PMMA restoration in the increased vertical dimension of occlusion, but we also had to do something for the left side because there was an old PFM crown, porcelain fused to metal crown, and we also need to make some provisional in order to make sure that we are increasing the vertical dimension of occlusion on both sides. So this is how it looks like after cementation, and we are already addressing the problem that the patient had by inducing some trauma to the anterior area. Okay, again with provisional restoration, providing the stability of the stomatognathic system. Because once we increase the vertical dimension of occlusion, there is no relationship anymore of the anterior teeth. So we really need to have the opportunity to make sure that we are stabilizing the mandible in a very stable relationship dictated by the masticatory muscles. This was a really challenging case that we worked with Dr. Goumenos. He's a periodontist here in Greece. This patient had no pain issues, no TMD problem. His concern was that, you know, my teeth keep disappearing. I used to have a smile where I could show my teeth, and now we don't see them anymore. And actually, it was mostly the concern of his wife and not so much of himself. So he's a young, big guy, huge, with a very small mouth though, but he's huge, and you know, then you see that when he speaks and when he talks, there's really no visibilities of the anterior upper teeth. So this is the initial panoramic. So we see that beside the class 3 relationship that he presents with, we have no posterior teeth anymore, so we lost the posterior support. And this is probably the reason why he moved his mandible to a more forward position in order to be able to function. But, you know, this was wishful thinking. We have to diagnose that and make sure that we are finding if the muscular skeletal stable position provides us with a better relationship of the mandible against the maxilla in order to address his chief complaint. Okay, so we need to, of course, increase the vertical dimension of occlusion, And all of that was done again in a digital manner, the whole diagnostic part, by having the intraoral scanning of this case, and of course making him a stabilization appliance. So this allowed us to make him a provisional restoration that would be that we were using, some teeth that would not interfere with our final treatment plan that would include the placement of some implants in the whole maxilla. So of course the rest of the provisional needed to be reinforced with metal in order to sustain all these forces that are applied during function for a patient, from a patient like that. And of course, this is also a restoration that would serve for a long time. Okay, so this is the provisional, this is how it looks like, and this is the relining that we're going to do after the extraction of the teeth. So as I told you, we're using some of them just to support the provisional restoration, and this is how it looks the day of the delivery. So already his wife, she was waiting outside for us to finish, and when she saw him, said, "Oh, you look exactly how like the day we get married." So this is the provisional. Now we let this function, and it allows us also to make some more diagnostical parts. So this would be give him some posterior support, initially with the removable partial denture, which would be a temporary one. So you see we use some orthodontic wires in order to support it. And then we proceed with all the other surgical part. So this would be, first of all, the extraction of the teeth, and then start with ridge augmentation on each section of the maxilla, so 3 different surgeries. And after the augmentation is done, we're going to place the implant. This is going to happen in September, actually, and it will be fully guided, of course. But in the meantime, we have all the time to diagnostically prepare the case, because in cases like that, probably the easier thing is to place do all the, well, I shouldn't say easy, but it's more predictable to proceed with the augmentation and placement of the implants. The challenging part here would be to find the musculoskeletal stable position and provide the 3 sigmas, the stomatognathic system stability, that would be functional but also aesthetic. So we proceed with the case. When the implants were placed in the mandible, we were able again with PMMA provisional restoration and adhesive abutments provide a stable occlusal relationship that was fixed. Remember, initially I used the removable partial denture, so with fixed restoration, provisional restorations over the implant, and this is how it looks. And now that all the ridge augmentation procedure finished in the maxilla, and because the temporary was really, many times relined and reused, I decided to make a new temporary restoration from him. This is a material that I like a lot for temporaries that are going to stay for a longer time. So the company gives it for up to 5-7 years, but it's a very nice material. And again, it was milled. It's actually a PMMA, okay, so it was milled. And I asked my lab technician to make me also a guide in the palatal, because once you take out the older ones, you need some guide in order to reline in the proper position that we found in a very difficult way for this case. So I used this palatal guide in order to do the relining of the upper temporary restoration, and this is how it looks like. We still have to work maybe a little bit on the occlusion, but I think that we're pretty close. And as I said initially, it's an easy way for us through all the diagnostic part to maintain the stability of the stomatognathic system. So I think with this, I would like to finish my presentation for today. I could go on for many hours on this topic, but I would like to give some time for the questions that you might have. And thank you once again for your kind attention and of course for the invitation.
Thank you so much, dear Ilya. I believe we all agree that it has been for a long time now a very important topic, the stabilization of the stomatognathic system. Yeah, but especially nowadays, I would say when lots of persons, everybody all around the world are getting more and more stressed about the whole situation that we are living, I believe this topic will increase the importance more and more. So thank you very much for the very didactic approach. As you said, it's a topic that one could stay hours talking, but yeah, but this little beginning, I believe, for the colleagues, it was very nice. So thank you very much. Questions are already coming. So first, our colleague, our distributor from the Emirates, Mr. Vihendra Shukla, he's always with us. He said, super presentation indeed. So he's congratulating your presentation. Thank you, Shukla, for being here. Looking forward to see you at the end of June during the ADEC in Dubai. The colleague Castillo asked, can you elaborate, please, regarding the deprogrammer? Can you talk a little more about deprogrammer?
Yes, of course. So the deprogrammer is actually a device that we use in order to register the musculoskeletal stable position, or the CR as we used to call it. So all we need is a device in the anterior area that would allow no contact at all on the posterior teeth. So once we have this device in the anterior area, we have to make sure that we are not guiding the mandible with the inclination of the anterior deprogrammer. So this is why we make it in such a way that we have the lower axis of the lower teeth perpendicular to the anterior deprogrammer. Because if this has an inclination, once the patient closes on that, it will guide the mandible to a different position. And then you can use any material you want in the posterior area in order to register that. But first, you need to use a stabilization appliance to guide the patient to this position. And then it's easy to register that with an anterior deprogrammer.
And also to Dr. Castillo is asking, after the deprogrammer, what do you place?
After the deprogrammer, no, the patient has always a stabilization appliance. So this is just for us to record the relationship in the clinic and send all the information to the lab in order to make the restorations, the provisional restoration initially. It would be nice in some cases to have the anterior deprogrammer as much, the thickness of it, as much as the increase of the vertical dimension of occlusion that we want to achieve. Because this will help us to give some stable relationship to the labs, that he won't have to change the occlusion, the pin of the articulating pin. So he will maintain the relationship that we are giving him. So the deprogrammer, we only use it for a little bit in the clinic to do the registration.
Thank you very much. The colleague, Dr. Saad, saying thank you very much for the important topic. Yeah, as we said, really important, Dr. Saad, and thank you very much for being here. And he's asking, how do you estimate the exact increasing the needed vertical dimension in millimeters for correction of the occlusion?
Okay, I'm sorry that I didn't have the time to go into details with that, but since we had the question, I would like to address it. So what I would do first is, with a digital smile design, assess where the incisal edge of the anterior teeth would be, actually of the two centrals, and start from there. So then I know how much I need to, how much prosthetic space I need occlusally. And from there on, I would go ahead and do my diagnostic wax-up all the way to the posterior upper teeth. Then with the information that we have from removable denture, I would measure the space, the occlusal space. And if we need to open a little bit more the vertical dimension of occlusion, I would go to the lower teeth. So aesthetic would guide me for how much I need to open. Sometimes it might be also the occlusal relationship than the case that I showed you initially with the telescopic occlusion. So even though the aesthetic will guide us to one point, we might get another 0.5 millimeter just to relieve the relationship of the mandible against the maxilla and give us a little bit more leeway space for the prosthetic space. But the bold guideline would be the digital smile design to decide where the anterior teeth should be.
Thank you very much, Dr. Shaikh from also from the Emirates. Like, hi to see you. Nice to see you, Dr. Shaikh here. He sent hi and thanks from Dr. Shaikh from Abu Dhabi. Nice to see you and looking forward to meet you again. Dr. Sheila, and thank you, doctor. This seminar was very useful. So also congratulating you. Dr. Mohammed Abdelaziz, also, yeah, nice to see you here, Dr. Mohammed, also to greet you. Is occlusal stabilization management will not disturb the implant osseointegration especially?
Okay, this is an excellent question because it brings us again to another topic that it's big, and that would be designing the occlusion over implant restorations. I believe that once we have these guidelines in our mind, how we should design the occlusion on the implant restoration, by having our patients in the stomatognathic system stability is the position where the forces that are applied are the least, because the muscles are functioning in their most stable relationship dictated by the tonus of the masticatory muscle. So we are distributing in a more efficient way the forces around the whole stomatognathic system. So I wouldn't be concerned about the occlusion more specific, as long as you take into consideration how we have to design the occlusion over implants. It's the same way how we take into consideration how we have to design the occlusion over two supported restorations. And again, this is a good point to mention it, that the stabilization appliance will be something that the patient will continue using for the rest of his life, because this is what is guiding us to find the 3 sigmas. So this is where we're building our whole full mouth restorations, and the patient should have the stabilization appliance to use for the rest of their lives, during sleep, of course, only.
Thank you very much. Dr. Zanoub, can the deprogramming be done with tensing units like the J5?
It could. I think it's another machinery that might be more difficult to use, rather than just doing a deprogrammer with a little bit of acrylic in our clinic. I find it in my hands to be a more easy and efficient and quick way to work with. And you can always use it during different steps of the treatment and reevaluate the registrations that you're taking. But certainly you could do it in this way as well.
Yeah, what is your opinion about the buccally erupting upper wisdom teeth, which may cause bit of convenience due to its symptoms in opening and closing the mouth? I have seen quite a few in my experience. So in terms of formulation of the question, if it's okay.
Okay. I'm not sure that I have faced these problems or seen this type of issues in my experience, but I would imagine that you mean because of the buccally position of the third molar, that it might interfere with the masseter during opening or during the lateral movements. You know, why not extract the third molar? I mean, even if it's so much out of place and out of the rest of the dental arch, I would certainly extract it if that's causing so much problem, especially during function.
Thank you very much. How to correct the shifted midline due to mole occlusion?
Okay, to be honest with you, I don't even look at the midline. I mean, I care about the midline of the uppers because I think it's an important aesthetic component, but I don't care so much about the midline of the lower teeth. And most of the non-orthodontic patients that I see, they don't have a coincidence of the midline of the upper and lower arch. So I'm mostly concerned about the whole position of the mandible and not so much about the midline of the lower teeth, because this could be due to many different reasons without jeopardizing the stability of the mandible against the rest of the cranium. If I understood the question well, I think yeah, that would be my approach.
Dr. Saad, yeah, just give please your feedback if everything's nice with the answer of Dr. Huso. The colleague also, Dr. Zanop, again, should aesthetic be the guide, or should it be the position where the muscles are relaxed?
Well, excellent question again. The muscles will dictate the position of the mandible, so in a three-dimensional way. Now, the vertical dimension of occlusion will be dictated mostly by aesthetics, because at the end of the day, our restoration shouldn't only be functional, they should also be aesthetically pleasing for the patient as well, but also for us. So once you have the position of the mandible in a three-dimensional way, you can decide how much you want to open or close the vertical dimension of occlusion according to the aesthetically and functionally limitations of this case.
Thank you. Yeah, Dr. Zaid said that everything was fine. He was the answer is completely correct, so to say. Dr. Nazin, then thanks a lot. And yeah, how much in millimeters the masseter and the temporalis muscle adapts to increase the vertical dimension?
Okay, that's again another excellent question. First of all, we have to make sure that there's no pain symptoms at all. I think this might sound basic, but it's important to mention it. Once we don't have any pain symptoms at all, and once we establish the muscular skeletally stable position, you can open the vertical dimension of occlusion. So the literature says 2, 3, 4 millimeters even, without having to go, without having any additional symptoms. In my clinical practice, I never had to open more than 2 millimeters in the posterior area. And you know, if you remember the rule 1, 2, 3, 1 millimeter in the first molar in the posterior area, it's about 3 millimeters on the articulating pin. So it's about 2.7 in the anterior area. So it's a lot of space. So I wouldn't expect to have a case to open more than, let's say, 3 millimeters. I never had to do that, even with the class 3 case that I showed you earlier. Because it's not only opening, it's also that the mandible changes again in a three-dimensional way, the position against the maxilla. If you need to open 3 millimeters or 4 millimeters, go ahead. Maybe the patient comes back within a week and they say, you know, it was a little bit difficult during biting and everything, but now everything feels good. Because it's also that they are missing this vertical component of their occlusion. So it's good to give it back to them.
Thank you very much. And yeah, Dr. Saad or Yasin saying again, satisfied and saying danke,
Okay.
thank you and danke, Peter, to Dr. Yasin. Bitteschön. The colleague Ebru, Dr. Ebru Ispirgil from Turkey, saying thank you so much for the nice presentation, Dr. Ilya. Sum it up, a very complicated topic perfectly. Yeah, for sure. Dr. Ilya will be back with us again. We've also different approaches on the same topic. Yeah. Looking forward for new presentations. Yes, for sure, for sure. There we're gonna be. Thank you for the wonderful lecture, Dr. Ziad Habayan. Thanks, Dr. Nassim, sent to you. Dr. Sayed, thank you so much. Yes, I believe this, yeah, this says a lot about this session. That was really very nice. Ilya, and I believe it was the last question. Very informative lecture. Thank you. Now it's pumping. Lots of thank you.
I'm very happy.
Yeah, we would like to thank you very much. It was the first, and for sure we're gonna have another sessions with you. I would like to thank you also everybody for attending this this web seminar with us. Yeah, and hope to see you again soon live. And I wish everybody to stay very healthy. Thank you very much.
Thank you. Bye bye.
Bye. Have a nice day. Bye, everybody.